Good morning, good afternoon, good evening to you all, and welcome to this webinar on management of post-PCI angina. I'm delighted to have here with me two good friends and key opinion leaders and experts in the field, Professor Magdi Abdelhamid and Professor Luis Enrique Godak, coming from, respectively, from Egypt and from Brazil. I mean, from two extremely busy centers, so with a lot of clinical expertise on the specific issues that we will be dealing with today. Now, and welcome to this second webinar of the series of the Angina updates. I believe that most of you have already visited the website and have already been accustomed with the format of the webinar, with the content, with the live material, and with the updates. And I invite all of you to check regularly the website, because that will give you all the news and information on new papers, new trials, and new updates on angina, as well as in the next month, from the next month, tutorials on vascular ultrasound. So the first speaker for today, as I said, is Professor Magdi Abdelhamid, that is Professor of Cardiovascular Medicine at the Faculty of Medicine, Cairo University in Egypt. He has an incredible CV that will be too long to mention, but he's been the principal investigator of the ischemia trial. He's the immediate past president of the Egyptian Society of Cardiology and chairman of the Working Group of Heart Failure, as well as board member of the Heart Failure Association of the ESC, where he's a co-chair of the Acute Heart Failure Scientific Committee, and he's also member of the Committee for Practice Guidelines of the European Society of Cardiology. He holds several positions, and he's also in the board of the ESC Journal of Heart Failure. So without any further ado, I'll pass it to Professor Abdelhamid, that will discuss the management of post-PCI and pathophysiology and size of the problem. And before I do so, I'll invite all of you to use the chat function to put your questions that will be answered either at the end of each talk or at the end of during the discussion session. Please, Professor Abdelhamid.
Good evening, everyone. Thank you very much, Professor Rosano, for this kind introduction. It's my pleasure to participate in this very interesting project, which is Angina Updates. And today we are going to talk about a very challenging topic, which is post-PCI angina. The resistance of chest pain after PCI is a clinical challenge for cardiologists for both diagnosis and treatment, because the recurrence of chest pain after PCI, successful PCI, is frustrating for patients and clinicians as well. So I'm going to touch the problem of physiopathology and size of the problem. This is my disclosure. We know that in the last EC guidelines 2019 for chronic coronary syndrome, we have the entity of patients who have asymptomatic and symptomatic patients with stabilized symptoms less than 1 year after ACS, or patients with recent revascularization. And the same for patients who will be symptomatic after 1 year after the initial diagnosis or revascularization. So it's common to see patients who were subjected to PCI and still are complaining of chest pain. And we know from the same guidelines that general management of patients who have chronic coronary syndrome is to relieve symptoms as well as to improve prognosis. So PCI can alleviate symptoms in patients with chronic coronary syndrome who do not respond to optimal medical therapy and might improve the prognosis as well in patients with acute coronary syndrome. However, previous studies have shown that angina pectoris can recur in patients who have been subjected to a successful procedure. So this is an interesting meta-analysis of randomized controlled trials, compared PCI versus medical therapy alone in patients with stable obstructive coronary artery disease and myocardial ischemia, included important studies like COURAGE trial, PARI-2D trial, FAM2 trial, and overall, we can see that the net benefit in terms of mortality, non-fatal MI, unplanned revascularization, as well as angina also, were not statistically significant in favor of PCI compared with medical therapy. Although we have seen a significant reduction in unplanned revascularization and angina as well in patients included in the FAM2 study. Again, we can see the percentage of patients who are angina-free in different studies and registries, like CAST registry, COURAGE trial, PARI-2D PCI or CAPEG, FAM2. And overall, we can see that in CAST study, the reduction in angina was statistically significant, as well as in meta-analysis published in 2012. However, in COURAGE, PARI-2D, as mentioned, the angina-free patients were not high compared with revascularization. And recently, we have the landmark study schema trial, which I'm proud to be one of the investigators of schema trial, a trial which included 5,179 patients randomized to PCI or revascularization, PCI or CABG versus optimal medical treatment. Patients who have moderate or severe ischemia identified by the core lab, and of course excluded patients who have left main disease. And we know the primary endpoint, which was the composite endpoint of cardiovascular death, myocardial infarction, hospitalization due to heart failure or unstable angina, or resuscitated cardiac arrest, was not statistically significant compared to both invasive as well as conservative strategy. However, if we look for the impact of ischemia trial on chest pain or angina, we can see that patients with stable coronary artery disease and moderate to severe ischemia had significant durable improvement in angina control and quality of life with an invasive strategy if they had angina daily, weekly, or monthly. However, in patients who were not complaining of angina, the outcome was not different between PCI or revascularization and the conservative strategy. So approximately 20 to 40% of patients are still complaining of chest pain after successful PCI. Persistent or recurrent angina after PCI is associated with significant economic burden, and the healthcare costs may be almost twofold higher among patients with persistent or recurrent angina post-PCI versus patients who are free of angina after PCI. This is an interesting retrospective study which included 400 patients with a STEMI looking for the effect of multiple clinical factors on recurrence of angina after PCI. And interestingly, they found that patients who had the PCI for LAD, as well as patients subjected to femoral approach for PCI, had a recurrence of angina compared with patients who were revascularized for other vessel compared with LAD, or patients subjected to radial approach during STEMI. So what are the potential causes of recurrent angina? We have structural causes, as well as functional causes. So very simple cause for chest pain after PCI is a stretch pain. It's a common condition, have been seen in 36 to 41% of cases. And it develops in the immediate phase after stent implantation due to overstretch of the treated vessel segment. It is not associated with myocardial ischemia, and it carries a benign prognosis. However, we have other structural causes, stent thrombosis, which is a devastating complication of PCI procedure. 1% in 1 year incidence of stent thrombosis, in spite that we have now the third generation drug-eluting stents, and we are using the potent P2Y12 inhibitors. Stent thrombosis is a serious condition excluded in patients who have chest pain after PCI. In-stent restenosis, incomplete revascularization, coronary artery disease progression, and the myocardial bridge are the common causes for chest pain after PCI. Up to 1/3 of patients with recurrent chest pain after PCI don't have an evidence of obstructive coronary artery disease. So what are the causes of chest pain? Epicardial coronary spasm, which can be seen often at the stent edge, or microvascular dysfunction. Patients who have endothelial dysfunction can predispose patients treated with PCI to the development of stent failure in the form of in-stent restenosis, as well as coronary artery disease progression. This is a very interesting paper which was published in the European Heart Journal 2019, Mechanisms and Diagnostic Evaluation of Persistent or Recurrent Angina Following a PCI. This was published by the Coronary Vasomotion Disorder International Study Group, COVADIS. And in this interesting paper, they summarize, as you have seen in this figure, the different structural causes for chest pain after PCI, residual disease or disease progression, in-stent restenosis and stent thrombosis, diffuse coronary atherosclerosis, intramyocardial bridge, as well as coronary dissection. And this causes can be seen in up to 20 to 40% of patients who develop chest pain after PCI. However, the functional causes could be epicardial coronary artery spasm or microvascular dysfunction. So this is the diagnostic criteria for different causes of chest pain after PCI. In-stent restenosis is defined as presence of 70% or more stenosis in the stented segment and within 5 millimeters of stent edges at the coronary angiography. In borderline lesions, FFR should be done to identify the significance of in-stent restenosis. Stent thrombosis, which is a serious condition, it is a presence of intracoronary thrombus that originate in the stent or segment 5 millimeter proximal or distal to the stent in the first 48 hours time window, which is an acute stent thrombosis. It is associated with acute onset of ischemic symptoms at rest, new ischemic ECG changes that suggest acute ischemia, typical rise and fall in cardiac biomarkers. Coronary artery disease progression, which is a common cause for chest pain after PCI, which is different from vessels treated with PCI in the presence of 70% or more stenosis in a vessel at coronary angiography. Incomplete revascularization, which can be seen around 30% of patients who have angina after PCI. It is a residual stenosis, more than 50% left main, 70% or more in other epicardial vessels. Again, in vessels who have a disease in the range of 40 to 70%, physiological lesion assessment using FFR is of important value. Diffuse coronary atherosclerosis is one of the causes. Myocardial bridge, systolic narrowing or squeezing of the vessel during systole, and the complete or partial decompression in diastole is a common cause for angina following a PCI, and spontaneous coronary artery dissection, which is separation within the arterial wall by intramural hematoma, and more commonly spontaneous intramedial hemorrhage resulting from disruption of the vasa vasorum. This is a very interesting slide showing the mechanism of stent failure due to development of in-stent restenosis. And we can see that this is before PCI. We can see the plaque in an atherosclerotic coronary vessel and the presence of macrophages, smooth muscle cells. And immediately post-stenting, we can see endothelial denudation, platelets, fibrinogen deposition, and then followed by leukocyte recruitment, cytokine release, such as interleukin-6, and this will be followed by more leukocyte infiltration, smooth muscle cells proliferation and migration, growth factor release like platelet-derived growth factor, insulin-like growth factor, transforming growth factor beta, and this will lead to, at the end, new intimal thickening, new intimal growth, due to smooth muscle cell proliferation and macrophages recruitment. Finally, we will have a significant atherosclerotic lesion, which is responsible for in-stent restenosis. What about functional causes? In the absence of significant coronary artery obstruction, we have epicardial coronary spasm, which is the presence of focal or diffuse epicardial coronary artery diameter reduction, 90% or more during intracoronary injection of acetylcholine or ergonovin, which can be relieved by intracoronary nitroglycerin, associated with typical symptoms, angina, and ECG ischemic changes. Microvascular spasm, it is typical ischemic ST changes, and angina developed during intracoronary acetylcholine in the absence of epicardial coronary constriction. No significant coronary obstruction in the epicardial vessels, 90% or more. Impaired coronary microvascular dilation, it is a reduction of coronary flow reserve less than 2 in the absence of obstructive epicardial coronary artery, and the increase in the index of microvascular resistance more than 25. And these variables can be estimated in the cath lab. This is the diagnostic criteria for microvascular angina. If we have symptoms of myocardial ischemia, effort or rest angina, exertional dyspnea, absence of obstructive coronary artery disease, detected by coronary CT angiography or invasive coronary angiography, objective evidence of myocardial ischemia, reversible defect detected by functional imaging test, and evidence of impaired coronary microvascular function, which is an impaired coronary flow reserve, less than 2, coronary microvascular spasm, symptoms, ECG changes, no epicardial spasm, and abnormal coronary microvascular resistance more than 25. And this is a typical example for the upper panel, one patient, 55-year-old, who was subjected to PCI for right coronary artery many years ago. And he has typical chest pain. We can see the baseline coronary angiography after injection of acetylcholine 80 microgram. We can see complete spasm of the epicardial coronary artery, which is associated with typical angina and ECG changes. And look for, after intracoronary nitroglycerin, complete filling of the epicardial coronary artery, RCA, distal to the stent, the vessel is filled well, and the relief of angina and ECG changes. But if you compare this patient with the second patients, the second panel, we can see a patient who was subjected to PCI for LED and still complaining of chest pain. And we can see that stent, mild or minimal in-stent restenosis in the proximal LED. However, after acetylcholine 200 microgram injection intracoronary, we can see that the ischemic ECG changes as well as development of chest pain. However, after nitroglycerin injection, we can see that the disappearance of the ischemic ECG changes and the relief of the chest pain, which prove the presence of coronary microvascular spasm as a cause for recurrence of chest pain after PCI for LED. So diagnostic approaches for those patients who are complaining of chest pain after PCI is very important. So accurate evaluation of symptoms is important. If this is true angina or chest pain due to other causes, lung disease, gastroesophageal disease, musculoskeletal disease, not related to myocardial ischemia. The time window between the procedure and new onset of symptoms, the longer this interval, the higher the probability that symptoms are due to coronary artery disease progression rather than other causes. Compliance to dual antiplatelet therapy, because premature discontinuation of that therapy is one of the most common causes for stent thrombosis. If the patient has an angina at rest, frequently nocturnal, with preserved effort tolerance, this is a suggestive feature of vasospastic angina. A prolonged chest pain not immediately responsive to nitrates is characteristic for patients who have microvascular angina. So we have many diagnostic evaluation methods or tools which can help in diagnosis of patients who have angina post-PCI. The non-invasive diagnostic test, we have stress test or stress imaging, which is considered a class 1 level of evidence C according to the EC guidelines. And also we have stress myocardial perfusion imaging, SPECT. We have positron emission tomography. PET is well-validated technique, non-invasive, accurate, reproducible. You have to quantify the global and regional myocardial blood flow. You can estimate coronary flow reserve as well. And stress echocardiography using either exercise or pharmacological stress like dobutamine stress echo, which can diagnose the presence or absence of significant myocardial ischemia. Invasive diagnostic test, coronary angiography, is class 1 level of evidence C in patients who have a high-risk ischemic findings by functional imaging. 10% or more of the myocardium is at risk, and it is downgraded to class 2B in patients at lower risk after PCI. However, if the patient still complaining of angina, like Canadian Cardiovascular Society classification 3 or 4, not responding to medical treatment, those patients should be subjected to coronary angiography to rule out the cause of angina. So invasive coronary angiography can identify the presence of subcritical unstable coronary plaques, which can be further investigated by intravascular imaging like OCT and IVUS. The assessment of epicardial and microvascular coronary vasomotion as a cause for angina can be also done during invasive coronary angiography. And this is from the same paper. We can see that in the cath lab, if disease progression or residual disease is present, then we have to assess the significance of this lesion by the use of physiological lesion assessment, pressure wire, FFR estimation. We have the option to use intravascular imaging, OCT, IVUS to identify unstable coronary plaques. If we don't have these abnormal findings by coronary angiography, then we have to assess microvascular disease. We have to use acetylcholine or ergonovin to test the epicardial or microvascular spasm, as mentioned before. And this is examples for one patient who has epicardial spasm during acetylcholine, and we can be sure that this is due to epicardial spasm, can be relieved by intracoronary nitroglycerin. And the second example for patients who have coronary microvascular spasm in the absence of significant epicardial coronary spasm. And this is interesting slide which shows different pictures for assessment of stent failure using IVUS and OCT, like new intimal hyperplasia, like new atherosclerosis, late acquired malacquisition, stent under expansion, which is common cause for chest pain immediately after PCI, and this can be treated well by the using of high-pressure non-compliant balloon. So we have to rule out mechanical causes for stent failure, malapposition, underexpansion, or edge dissection. So the use of intravascular imaging tools, IVAS and OCT, can delineate the abnormality post-stenting to see or to rule out mechanical problems. This is a very interesting slide which shows the algorithm how to deal with patients who have recurrent persistent angina post-PCI. Proper clinical evaluation, standard 12-lead ECG, routine blood test. If we are dealing with patients who have acute coronary syndrome, so urgent management according to the EC guidelines is highly recommended. In patients who have chronic stable angina, will be subjected to functional imaging. So if we have positive tests for ECG abnormalities, development of angina without regional motion abnormalities, optimal medical treatment is recommended. But in the presence of regional motion abnormalities, in addition to angina and ECG changes, coronary angiography is highly recommended. In the presence of mild stenosis, functional assessment should be done. Spasm provocation by acetylcholine or ergonovin are indicated. Estimation of coronary flow reserve and IMR is indicated. In the presence of intermediate stenosis, physiological lesion assessment by FFR is mandatory. And in the presence of severe stenosis, patients should be subjected to repeat PCI. If functional imaging is negative, then we are dealing with non-cardiac chest pain. You have to rule out other causes for non-cardiac chest pain. And this is another figure, which another algorithm, the same. According to the clinical probability of angina, recurrent angina is an indication for coronary angiography. Severe lesions should be subjected to PCI. Intermediate probability, we have to rule out ischemia, exercise ECG, myocardial perfusion imaging, stress echo, CMR, and if it's positive, coronary angiography is indicated. And in the absence of ischemia, we have to rule out other causes for non-cardiac chest pain. And in intermediate lesions, FFR is mandatory to assess the significance of coronary obstruction and the need for PCI. So the take-home message, ladies and gentlemen, that after a successful PCI, still we have 20 to 40% of patients present with angina. And this problem is associated with significant morbidity and cost. And it is a challenging condition for patients after being subjected to PCI, which represent a burden for the healthcare cost. Structural and functional causes are responsible for recurrent angina, so treatment modality depends upon proper diagnosis of the etiology. Thank you for your attention.
Thank you very much, Professor Abdelhamid. It was a great talk, and I'm sure looking from the questions we're receiving, it will generate a lot of discussion on a real clinical scenario, because that is what is then important on how to deal with our patients. And I suggest that we move to the next presentation, and then we'll have the discussion at the end. And therefore, it is a great pleasure to invite Professor Luis Enrique Godach, who is Professor of Cardiology at the University of Sao Paulo in Brazil, and is a clinical scientist at the Heart Institute at INCO in Sao Paulo, Brazil. He has many achievements, and he has been working with the NIH in Baltimore on therapeutic angiogenesis, and he founded the first clinic on refractory angina research in Brazil, and is a fellow of the European Society of Cardiology. So, Professor Godach, please, the floor is yours.
Thank you so much, Professor Rosano. Just please confirm that you can see my slides. Is that okay?
Yes.
Okay, wonderful. So thank you so much for the invitation and to be part of this webinar. And before I start, I'd like to make a small reference, a special thank you to Professor Rosano for this initiative, the Angina Updates project. And he was kind enough to put me on this project as representing the Latin America countries. So Professor Rosano, grazie mille for this special invitation for a nice, wonderful project. So you heard from Professor Abdelhamid, nice presentation, all the basics, the physiopathology of why patients can return after a successful PCI. They can return to our office complaining of angina. So in the next 25 minutes, I will try to show to you what should be the best practices for the management of patients with post-PCI angina. These are my conflicts of interest. So what are the best practices for the management of post-PCI angina? Well, when I was given this title for my presentation, you know, I thought a little bit, and maybe the management of patients with post-PCI angina would have to start before the PCI for angina. So I would like to spend a couple of minutes. Why are we referring patients with angina, with chronic coronary syndromes for a PCI, and what does it have to do with the late after PCI, the patient comes back with angina? So we all know that PCI in patients with acute coronary syndromes is a life-saving strategy. So you see a patient complaining with the acute symptoms, very intense, heavy symptoms. You rush this patient to the ER, and this patient is admitted in the emergency room. You run an ECG, you see a STEMI going on, so there's an ST elevation, myocardial infarction, and you bring this patient to the cath lab. You perform a primary angioplasty with the culprit, within the culprit area, artery, and you know the patient is safe, hopefully, from this tragedy, which is an acute coronary syndrome. So not much doubt about the role of the PCI in the acute setting. So a primary PCI, this is from the guidelines. So a primary PCI strategy is recommended, class 1 level recommendation, class 1A over fibrinolysis within indicated time frame. So it's a life-saving procedure here. But when it comes to the chronic coronary syndromes, so the role of the PCI is it's more challenging to find the role of the PCI in terms of impacting prognosis and for a better symptom control. So as Professor Abdelhamid showed us, so you see a patient complaining of angina, stable symptoms, and you decided to perform a PCI to relieve symptoms in that particular patient, and the patient is quite happy for a while, and then maybe a couple of weeks, couple of months after the procedure, the patient comes back, you know, telling you, you know, doc, my pain is back. I'm having the same chest pain I used to have before, or, you know what, doc, I never get rid of the pain. So I was okay for a while, then I started exercising again, and I had the same pain again. I had the same chest discomfort I used to have. So what happened here? So when you look at the guidelines for the indication for revascularization in patients with stable angina or silent ischemia, and you are considering the procedure, for a better symptom control, so you are considering revascularize a patient for symptoms, you have to fulfill 3 main criteria to get a class 1 level recommendation A, class 1 A. Which are the three main, the basic aspects to refer a patient for a procedure? Well, you have to have a hemodynamically significant coronary stenosis. So in order to refer a patient for a revascularization procedure, the patient has to have a significant coronary stenosis. But pay attention, there's a small tricky here. There's a very small letter here. It's hard to read. It's a small C. And what that small C stands for, okay, let's see here. Okay, so you have to have the stenosis, but with documented ischemia. You have to have documented ischemia, or at least, if you perform an invasive assessment of the physiology of that lesion, a hemodynamically relevant lesion defined by FFR or IFR. So stenosis with documented ischemia, rule number one. Rule number two, you have to have limiting angina or angina equivalent. So you have the stenosis, documented ischemia in the presence of limiting angina. This is rule number two. And rule number three, with insufficient response to optimize medical therapy. So you have to fulfill these three main criteria to consider a patient eligible for a revascularization procedure: stenosis, hemodynamically significant in the presence of limiting symptoms with insufficient response to optimized medical therapy. It seems crystal clear, right? Well, not so much. When you come to the clinical practice and the way many of us, many physicians are treating our patients complaining of angina, you may have a disappointment here. You see in this data, you have more than 1,200 patients complaining of angina. And how are they being managed by their physicians? You have a staggering number of 44% of those patients with frequent angina on suboptimal anti-anginal therapy, meaning that they were on no therapy whatsoever, or at least taking just one anti-anginal medications. But you know, we have many options to treat those patients, but still they were being undertreated. Although being symptomatic, they're being undertreated. And when you look at the patients being referred for PCI, so now I decided to refer a patient for PCI as a strategy for revascularization. Look at this. Now I'm showing to you a large registry from many years ago, 300,000 procedures, 300,000 patients referred elective PCI. And let's see what were the main clinical characteristics of those patients in terms of anti-anginal medications. Are you ready? Here it goes. So this is right. We have here at least almost 1/3 of all patients being referred for PCI, elective PCI, they were taking no medications for symptoms, no medications. And when you consider what the guidelines now say, that many patients will have to have at least 2 anti-anginal drugs, the numbers come to 20% or less. So I'm referring a patient, elective patient for PCI, without treating those patients properly in terms of anti-anginal therapy. And I'm referring those patients for a procedure for better symptom control. And what about optimal medical therapy after PCI? So we can start to understand, why do we have such high rates of post-PCI angina? So this is data from a Canadian study looking at the patients referred to a PCI. And let's look what is optimal medical therapy for symptoms before PCI and after PCI. You see, when you look at patients post-PCI, 3 months later after the PCI, they were still symptomatic, and compared to the baseline before PCI, I just de-escalated my symptom-oriented medical therapy. So because of the PCI, I assume my patient is good to go, is free of symptoms, so I tend to de-escalate the anti-anginal therapy. And this is true even for patients. When you compare complete revascularization with incomplete revascularization, we just learned from Professor Abdelhamid's presentation that incomplete revascularization may be one of the main different causes for post-PCI angina. So if you perform a complete revascularization and you look at the rate of the angina percentage of patients at 6 months mark, there's no difference between how will you treat those patients? De-escalate, don't change the medication, or you escalate the medication. But still, between 20 to 25% of those patients, even having undergone a complete revascularization, will come back with angina. But look at the patients that you had a multivessel patient, a multivessel disease patient laying at the table, you perform 1 or 2 PCIs, you know that the revascularization was incomplete. But at 6-month mark, you de-escalate the anti-anginal therapy. No surprise that almost half of those patients will still have angina, but the physician decides to de-escalate the anti-anginal therapy. So something is missing here in terms of optimal medical therapy for those patients. So this is the first topic I'd like to address. The second is, this is a costly procedure. Are there any risks associated with the PCI in an elective setting? Well, yes, there are many risks associated with the procedure itself. Here we see, this is recent data, more than 25,000 patients having undergone PCI with different devices, bare metal stents, first generation, second generation of drug-eluting stents. And you see here that there is a significant drop coming from the bare metal stents to the second generation of drug-eluting stents in terms of a composite of major adverse cardiovascular events. But if you survive the first year, and now you look up to 5 years, there is basically a steady growth of 2% rate per year of a cumulative rate of major adverse cardiovascular events, and there is not much a difference between the device, the type of device being used for that procedure. So it looks like that the stent-related events continue to accrue at a rate of approximately 2% per year between 1 year and 5 years after the PCI, with all metallic coronary stents, regardless of its bare metal or second-generation drug-eluting stents. We learned from Professor Abdelhamid again, stent thrombosis, you may have a peri-procedure MI, restenosis, and you may have to have another revascularization. But the thing is that this rate has not meaningfully improved as the stent technology has evolved from the bare metal stents to contemporary drug-eluting stents. We don't see a plateau here. So this ongoing risk is evident and may signify a lifelong patient concern at a rate of 2% per year. And we all know that peri-procedural myocardial infarction may occur during elective PCIs. And what is the prognosis meaning? What is the prognosis impact of having a myocardial procedure, a peri-procedural myocardial infarction? Well, comparing to patients undergoing elective PCI without any procedural event like myocardial injury or type 4 MI, there is a significant decrease, very small, but the sign is there in terms of survival free of cardiovascular events. And when you look at the bigger magnification of these numbers, the sign is here. As long as you have a myocardial injury, you have a higher risk for future cardiovascular events. And the same goes for ischemic events. So again, if you have a peri-procedural myocardial infarction, you may be exposed to a higher rate of ischemic events during the first year after an elective PCI. So at this part of my talk, it may come as a shock, like this young lady is reading the news or letter, I don't know, that we're offering our patients suboptimal medical therapy for better symptom control, if any, when we decide to offer before PCI. Many patients go for a PCI being asymptomatic or with minimal ischemia demonstrated. Anti-anginal therapy de-escalation after PCI may occur even in patients with angina, which of course will help us understand why we have this high rates of post-PCI angina. PCI-related cardiovascular events, including peri-procedural myocardial injury, pose a risk for the patient, and of course there are costs to the healthcare system. So before we worry about the post-PCI angina patient, we have to consider how to best offer this valuable, wonderful tool called PCI to the patient with stable symptoms. So To the next part of my talk, now I will talk about the best practice for the management of post-PCI patients complaining of an angina. So I'd like to start this next part of my talk coming back to the Courage trial, all familiar with the Courage trial. Here, what we see in the left part of this panel, we see the percentage of patients who were angina-free in the first 3 years of follow-up. What you see in the dark blue bars here are the patients in the arm PCI plus optimal medical therapy. And in the light blue bars, patients on optimal medical therapy. So what the data shows that after 3 years, there's no difference whatsoever between the two strategies. But I'd like to draw your attention, not that there's no difference, but between the two strategies. I would like to draw your attention to those numbers inside within the bars, 59 and 56, angina-free patients, meaning that I have another 41 or 44% of patients who may or may not have undergone a PCI who were on optimal medical therapy and still complaining of angina. But they were being treated after 3 years. Yes, certainly they were being treated. And this is how they were being treated for symptom control. Beta blockers, calcium channel blockers, long-acting nitrates, and now here you can see the percentage of use of those anti-angina drugs. So beta blockers, calcium channel blockers, and long-acting nitrates being used between 40 to 80, 85% of those patients. But they were still symptomatic. So this is something to think about. Why those patients were still symptomatic and why we didn't push for a higher usage of those anti-angina drugs if the patients were still symptomatic. Well, we learned from Professor Abdelhamid's presentation that the post-PCI angina patient is a multifactorial entity. You have structural, stent-related causes, you have functional, but if you think in a broader sense, if you consider the patient complaining of angina, actually, all patients with angina are not created equal. So even before the PCI, many different mechanisms, and Professor Abdelhamid presented this very nicely. So you may have a patient complaining of angina because of myocardial ischemia, because of a fixed atherosclerotic nerve, but they may have a vasospasm because of endothelial dysfunction. They may have a microvascular dysfunction. And many patients will have an overlapping mechanism for myocardial ischemia. They may have a significant non-obstructive stenosis with vasospastic or with microvascular angina because of microvascular dysfunction. So the cause for myocardial ischemia is also multifactorial. So we have to take this into consideration when you are considering the best strategy to treat any patient complaining of angina before or after a PCI. And what I think was missing when you were just tackling angina, you were attacking angina by using beta blockers, calcium channel blockers, and long-acting nitrates. You were considering just the main mechanism, considered like a fixed stenosis, effort-induced, but you are not considering the cell, the cardiac cell, all the metabolic alterations that happen during sustained periods of ischemia, like you still have an increased fat acid oxidation at expense of decrease in glucose oxidation, which is a less efficient system to produce ATP because it demands a lot of oxygen to make the system running. But we can fix this metabolic alteration during ischemia by blocking the beta oxidation, the free fat acid oxidation by trimetazidine. We can do this. And when you do this in patients, for instance, after PCI, who were on a beta blocker, like taking metoprolol, they have a PCI, they were still symptomatic, and you see here the number of angina attacks per week. When you combine a beta blocker like metoprolol with trimetazidine, you basically reduce the number of angina attacks by 50%. So there's a synergistic effect here. You were decreasing the demand of ATP by a beta blocker strategy, and you are optimizing the production of ATP by trimetazidine, and the clinical result is a significant decrease in the number of angina attacks. And also, you increase, there's a gain in exercise capacity in combined strategy. So patients are more exercise tolerant when you combine a beta blocker with trimetazidine. And it's interesting because we have this data in almost in more than 500 patients. They were elderly patients, multivessel disease. They had diabetes. They were randomized. They underwent a PCI, and they were randomized to a trimetazidine or usual care. And in the first 2 years after the implantation of drug-eluting stent, there was a significant reduction by trimetazidine in the number of patients coming back with angina. And when we look at the predictors of the recurrent angina pectoris, you see here in this table, the use of trimetazidine was associated with a significant decrease in the risk of a recurrence of angina in the first 2-year period. So this is very interesting. And we may have in the same study a significant decrease in the recurrent angina after stent, and also silent myocardial ischemia in patients taking trimetazidine compared to the usual control, the usual standard of care. And because trimetazidine improves the production of ATP, this is an extra benefit of targeting the cardiac cell. There's an improvement in LV function. Although those patients, they still have a preserved LV function, compared to the baseline, there was a significant increase in LV ejection fraction compared to the usual care. So this is very interesting. But many times in the clinical practice, you see a patient coming to you after many years, after a PCI or revascularization procedure, or even that patient has been suffering for so many years. Is it worth to consider targeting the cell even if the patient has a long history of stable angina, complaining of symptoms? Yes. This is data from Professor Maria Glaser from the Russian Federation. And we see that regardless of how long the patient has been suffering from angina, less than 1 year or more than 9 years, as soon as you add trimetazidine to those patients, you'll get a significant decrease in the number of angina attacks per week. And this is very important, may I remind you, because the new European guidelines made a special consideration to those patients with newly diagnosed angina, patients with recently diagnosed angina. We have to offer a fast, reliable, efficient, well-tolerated symptom control. And trimetazidine can provide that even for patients with a recent diagnosed angina. And another interesting is that trimetazidine may have an impact after a PCI in the number of cardiovascular events and even stent restenosis. So this is data from Professor Chen from China, in which in more than 600 patients, she showed that in the first year, patients on trimetazidine compared to usual care had a decrease in the number of stent stenosis and the number of combined cardiovascular events, showing that there may be a sign here for cardioprotection in those patients. And the same goes again, 100 patients before, after treatment, usual care, trimetazidine on board, quality of life, more able to exercise. Here I'm showing the walking distance after treatment. So you are making your patient more able to exercise. Your patient is, the quality of life goes up because the patient can exercise more, is free of symptoms. And this is how it's measured. We have different questionnaires. This is just the Seattle Angina questionnaire. And you see that in the experimental group, meaning I'm giving trimetazidine, all parameters here, meaning physical limitation, angina stability, angina frequency, treatment satisfaction, or disease perception, all those parameters are higher than the usual care, meaning that trimetazidine can be of benefit in patients who remain symptomatic after a PCI. And a small word here on myocardial protection. Remember, I showed that peri-procedure myocardial injury is a marker of poor prognosis in patients undergoing elective PCI. Can we protect the cell can we protect the cardiac cell using trimetazidine before the PCI? So when the PCI happens, the PCI occurs in elective patients, the cardiac cell will be prepared for the PCI. Well, we can do that. This is a study with more than 250 patients, usual care compared to trimetazidine given before the PCI, right before the PCI. And here you see the circulating levels of troponin I. This is the usual care, 24 hours. And here are the numbers for patients who received trimetazidine before the elective PCI. And you see there is a significant decrease in the release of this myocardial injury marker, troponin I, in patients receiving trimetazidine before the PCI. And in the same study, this is another study actually, this is a South Korea registry in patients with acute MI treated by PCI. 95% of those patients were treated by PCI. This is not a randomized controlled study, may I remind you. This is an observational study, a registry. And in those patients that in the first year after the acute MI who received trimetazidine had a significant reduction in cardiovascular events, including death and MI and the re-PCI, a targeted lesion revascularization. So trimetazidine may reduce. This is a registry, and we have to be careful in interpretation of the study, but this is very interesting data. And we have a meta-analysis showing the benefits of trimetazidine during PCI. We don't have many trials, but still all look at the same direction. So there is less angina attacks during PCI if you're using trimetazidine, less dynamic ischemic STT changes on ECG during PCI, and improvement in LV ejection fraction and myocardial protection with less release of troponin I. And just to summarize this part, because allow me to share the Brazilian guidelines, because in Brazilian guidelines for stable angina patients, along with the indication for symptom control, we have a clear indication in our guidelines that trimetazidine should be used in patients with stable angina undergoing myocardial revascularization procedures, such as PCI or CABG, to decrease the extent of myocardial injury. This is in our guidelines. Actually, it's a note guideline, but it's still used in Brazil. But to my final part of the talk, if you look back to this data, so what are we still missing in the Courage trial when you look at the percentage of patients taking all these combination drugs and still suffering from angina? So I'll change here to highlight this, the percentage of patients using beta blockers, 80%. So why don't we go up with the beta blockers, with the calcium channel blockers? Well, we have to look at the blood pressure in those patients. And here you see in both arms, the systolic and the diastolic blood pressure coming from the baseline, 1 and 3 years. And you see that at the 3-year mark, the blood pressure was roughly 120, 125 over 70. So there was not much room to go further in optimization of beta blockers, calcium channel blockers on long-acting nitrates because of tolerability. So we still miss here an opportunity to better treat those patients. And remember, when you increase the dose of beta blockers, maybe this is an example of the common say, when more is less. When you give more of that drug, maybe that drug will be less tolerated. So we have this concept in mind in clinical practice. So sometimes when you give more of the drugs, like in the beta blockers, you get more hypotension, more bradycardia without increasing any benefits. And when you look in the real world data, and you have to increase the dose of beta blockers, this is easier said than done. This is data from the Clarified registry, more than 32,000 patients with being assessed. And you see the recommended range here and what the physicians were able to give. There's a difference here, a huge difference between what I can give in clinical practice and what's the recommended range here. So, and this is particularly true for patients with a higher rate, like above 70 beats per minute. 70% of those patients were taking beta blockers and still have a higher rate. And this gets worse when you have patients with angina, because 50% of those patients on beta blockers will have a higher rate. So we have to do better. We have to do better.
And because we know that the increase in the heart rate is a trigger for ischemia, for symptoms, we have to have a better control of the heart rate. And that comes ivabradine in a hand, because ivabradine can significantly and safely reduce the baseline heart rate in a safely mode, very efficient. And compared to the beta blockers, there's a greater coronary flow reserve provided by ivabradine than by bisoprolol, for instance, for the same level of heart rate reduction, meaning that ivabradine does something else beyond the simple reduction in terms of heart rate. And when you look at the best strategy in terms of patients with angina, a combined strategy like a beta blocker and ivabradine will provide, like in this study, a faster and more significant reduction in the symptom control compared to a monotherapy with beta blocker. And you know what? You get more efficient control with a better tolerability profile. So less adverse events with the combined strategy than with the monotherapy high usage of beta blockers. And again, when you combine the strategy, your patients can exercise more. And in patients with angina, after PCI, when you had now ivabradine, there's a complete resolution of angina in the first 3 visits in this 2-month study, showing that a significant reduction of angina, significant reduction in short-acting nitrates, and an improvement in functional class of angina. And by echo, you show that patients can exercise more, and the threshold for ischemia is higher when you add ivabradine compared to usual care. So what were we missing? Have we found it, Professor Rosano? I think yes, we found it. So my last 2 slides. So I think that there's no universal definition which drug combination is optimal. Anti-ischemic drug therapies must be adapted to each patient's characteristics and preferences. The initial drug therapy usually consists of 1 or 2 anti-angina drugs as necessary, plus drugs for secondary prevention of cardiovascular disease. I didn't touch on that. And the choice of the anti-angina agent should match, ideally, the underlying mechanism for myocardial ischemia. And of course, it depends on expected tolerance related to individual patient's profile and comorbidities, potential drug-to-drug interactions. Many patients are taking drugs for hypertension, diabetes, hypercholesterolemia, patient's preference after being informed of potential adverse effects, drug availability in your country, and remember that the cardiac cell is a therapeutic target, and do not forget to include an effective heart rate control in your to-do list. Thank you very much, Professor Rosano, and I'll be glad to take any question from the floor. Thank you.
Thank you very much, Professor Godard. I mean, another great lecture, and we can see from the number of questions that we receive that it's both of your questions have generated a lot of interest and, of course, a lot of questions. Now, I would like to start with the first question to Professor Abdelhamid, and then Professor Godard can answer to follow. I mean, we have a lot of attendees that are coming from countries where there might be financial constraints. And we know that there is an indication to perform FFR in the majority of patients, but would you perform the FFR post-PCI as well? Or would you, for example, consider that if you check your PCI and you have a good angiographic success, but then there is some slow flow, then that can be enough to suggest that may be an underlying, say, microvascular disorder?
Great question, Professor Rosano. I think the availability of physiological lesion assessment, FFR, IFR in the cath lab is of paramount importance in evaluation of borderline lesions. I know that the availability, affordability is not the same in all centers, and in low-income countries. I can say that in the daily practice in the cath lab, the use of FFR is not a routine. It is not available in every cath lab. However, it is of great value in assessing severity of borderline lesions, especially if you have the residual lesion after doing the successful, apparently by QCA, that is well-deployed stent TIMI-3 flow. So if you have a residual lesion and you need to estimate the severity, or you have another native vessel which is borderline between 40 and 70, it's mandatory to have physiological lesion assessment in the cath lab. If you don't have the facility and you are not dealing with an urgent situation, ACS for example, you can assess the significance of this lesion by myocardial diffusion imaging or other methods for evaluation of the significance of ischemia in the territory supplied by this vessel. However, I know the problem of FFR, it's not available everywhere, but it adds very important significance to the success of the outcome for patients subjected to PCI.
Thank you, and that is a good segue to one of the questions that we received. Now, how can you suspect the presence of persisting angina due to microvascular disease after a PCI? So what will lead you more to bring that patient back to the cath lab, or whether to intensify your treatment?
Yeah, this is also a very great question, because coronary microvascular dysfunction is, according to one study, it is present in around 59% of patients subjected to PCI. So it is common, and for every 5 patients are complaining of angina post-PCI, coronary microvascular dysfunction is present in 1 for every 5 patients. And many mechanisms have been suggested for this, by the way, that before PCI, coronary microvascular adaptation to the low perfusion pressure distal to the coronary segment, there is a negative remodeling for the microvasculature, which cannot adapt after opening of the coronary artery. In addition, for drug-eluting stents provoke vasoconstriction for the adjacent coronary macro and micro circulation. And it is present even before PCI microvascular dysfunction. So if a patient has chest pain and not responding to proper medical treatment and subjected to coronary angiography, and there is no significant coronary obstruction responsible for angina, then we have to rule out epicardial coronary spasm as a cause, vasospastic angina. And if not present, then we have to suspect coronary microvascular dysfunction or spasm. Spasm can be provoked with intracoronary injection of acetylcholine. I know that this is not available also everywhere in the daily practice in the cath lab, and the number of centers doing this test when suspecting coronary microvascular dysfunction is not high, because also it needs a good experience and training. However, in the guidelines, it's considered a class 2A recommendation, EC guidelines, class 2A recommendation, and by the American guidelines, class 2B recommendation to do acetylcholine injection and to rule out coronary microvascular dysfunction and to estimate coronary flow reserve. And this can be estimated non-invasively by Doppler echo, or can be estimated in the cath lab by thermodilution or Doppler wire. So all these measurements can be done non-invasively and invasively when you suspect that this patient has no mechanical problem regards stent failure, has no vasospastic angina for the epicardial vessels, and most probably it's a coronary microvascular dysfunction, which is common, especially in women still complaining of recurrent angina after doing a successful PCI.
Professor Rosano, may I add something?
Absolutely.
May I?
Absolutely.
Thank you. I think the last comment by Professor Abdelhamid is so important, because I myself, I work in the largest hospital dedicated to cardiovascular medicine in Brazil. And I don't have on a regular basis FFR to assess my patients. You know, the Brazilian health system is a public one, is a universal, but is very good, but limited in resources. So maybe if you have a private health insurance, I can provide an FFR for you, but for the majority of the patients, I don't have this opportunity, this tool. But the thing is, if you have a patient with previous angina, then you perform a successful PCI, and that patient comes back to you complaining of angina, and you decided, you know what, let me run a treadmill test. And the treadmill test turns out to be positive for myocardial ischemia. And then you bring that patient to the cath lab, and you find that the stent is okay. So there's no problem with the stent. I've seen, unfortunately, physicians disregarding the symptoms of the patient because there is no problems with the stent. So it's like, you know, this was a false positive test for the treadmill test, or for the myocardial perfusion scan, if you will. And no, this is not angina. Maybe you were too worried. Maybe you're too concerned about the COVID-19. I don't know, you're too depressed. So maybe I'll give you some, I don't know, antidepressants, and you'll be okay. So what Professor Adel Hamid said is, you know what, maybe if you bring this patient to the cath lab and you find out that there's nothing wrong with the stent, there will be a secondary, probably myocardial ischemia mechanism responsible for the symptoms for your patient. So don't disclaim, so don't disregard your patient altogether because the stent looks okay, since you don't have this FFR or CFR or whatever FR you are measuring.
We have another question that is on whether you can detect different features in women compared to men. I mean, in your experience, do you see them different?
Well, if this is an interesting question. If you look now, let's say, at the pre-probability test of a man or woman to have significant stenosis related, obstructive CAD related to myocardial ischemia, all the numbers went down comparing to the previous ESC guidelines from 2013 to 2019. So usually the pre-test probability of a woman to have obstructive CAD compared to men as the main reason for their symptoms is slower than men, meaning that microvascular dysfunction and endothelial dysfunction and vasospastic angina will be more prevalent in women than men. So this is something you have to take into account when you were bringing that patient to the cath lab. And based on that, the medical approach, the medical treatment of that patient will be, of course, different because you have to consider the underlying mechanism for myocardial ischemia, if not a fixed stenotic coronary artery.
Yeah. Yes, and I believe that it's also there's a difference in age and also the changes in the duration of the chest pain, because with women tend to have more say prolonged episodes of chest pain just because of they more frequently have a microvascular angina, and that is characteristic starting soon after the menopause or a few years after the menopause, and then progressively worsening. So it's I think we sometimes we tend to underestimate the chest pain in women just because they report prolonged chest pain, and we say, oh well, this may not be cardiac because it's too prolonged, but that is a feature of microvascular angina that can coexist with very well with say an epicardial stenosis. Now, I have a question here on, and I would like to have your opinions, both of you, on the whether ivabradine and trimetazidine should be used are used for angina only or for mortality as well. So if I can ask you quickly, then I will give my point of view.
Okay, I can start probably. Well, first, no single anti-anginal agent has proven any benefit in terms of mortality for patients with angina. Unless, of course, you've considered, let's say, beta blockers right after acute MI or in patients with angina and LV dysfunction. But if you have a patient with angina, no single agent has proven any benefit in terms of mortality in that particular setting, stable angina patients.
I'd like to add that optimal medical treatment is very important. So we have to focus on blood pressure less than 140/90, LDL less than 55 milligram per deciliter, stop smoking, body weight reduction, statins should be add ezetimibe if LDL is not controlled, PCSK9 should be considered. I'd like to not only focusing on drug therapy for improving the outcome of patients, but we have to consider the optimal medical treatment. Because in the ischemia trial, for example, the outcome of medical treatment versus PCI was the same because those patients are well treated according to the definition of optimal medical treatment. So we have to consider when treating patients who don't have the mechanical problem related to the stents, whether you have diffuse coronary artery disease, microvascular dysfunction, we have to continue the drugs which improve endothelial dysfunction, because endothelial dysfunction is one of the most important contributing factor for progression of the disease, for in-stent restenosis, for coronary microvascular dysfunction. So this can be achieved with optimal medical treatment.
Yeah, no, absolutely. I fully agree with both of you, and especially with the point that there's not been a single study with any anti-anginal that has ever shown a benefit in mortality. And even for the beta blocker, we tend to take the data from the ISIS-1 study that supposedly showed a benefit in those patients with LV dysfunction. But then if you look at the overall trial, at 1 year, there was no effect on mortality. So, and also, I think it will be very pertinent and I suggest all of you to go and look at the recent issue of the European Heart Journal, where there's a largest study on beta blockers post-PCI, showing that there's no benefit whatsoever, and if anything, they increase events. So that is something that should be taken into account, given the very good safety on long-term on events with tremetazidine and ivabradine. Also, if we take data from all randomized clinical trials with ivabradine, we can clearly see that whether you reduce the heart rate with ivabradine alone or ivabradine plus beta blockers, those patients that get to a heart rate around 54 are those who benefit more. And those patients that take regularly tremetazidine tend to have a better quality of life. And if they have left ventricular dysfunction, there is also a compelling prognostic effect of tremetazidine. So I think that it is important to implement in all our patients these very important medications. And to follow that, I would like to ask you questions that just came through. That is it possible that the negative effect of chronic nitrate on platelet aggregation and on endothelial function may have an effect on the progression of atherosclerosis or on favoring restenosis?
I remember a couple of studies showing that the use of long-acting nitrates are certainly associated with the endothelial dysfunction
And this might be one of the explanation because of in 1 or 2 trials, long-term trials, 1-2 years follow-up, there was a higher incidence of cardiovascular events, including mortality, in patients who were taking long-acting nitrates. So when we were to update the Brazilian guidelines in 2014, we took that into account, and in our guidelines, the long-acting nitrates have been downgraded. Long-acting nitrates have been downgraded after beta blockers, calcium channel blockers, ivabradine, and trimetazidine at that time. So there may be a correlation between endothelial dysfunction caused by long-acting nitrates and cardiovascular events.
I'd like to ask a question. Is there a value for assessment of endothelial function before PCI to see the predictors for chest pain post-PCI, the presence of endothelial dysfunction before PCI can predict patients who will develop chest pain after PCI? If this is of value, or do we need to know what are the predictors? Because regarding the predictors, we know that patients who develop CKMP or troponin elevation post-PCI, those patients who will develop chest pain after PCI. So do we have other tools or imaging or markers to assess which patients who will develop post-PCI angina?
Well, I'm not aware of any trial that have prospectively tested this hypothesis. We know that, for instance, the lower the FFR before the PCI, maybe the higher the likelihood of that patient will be free of angina if you assume that you treat the right stenosis responsible for that symptoms. But as you pointed out, so maybe the patient complaining of angina after the PCI, because there are many different mechanisms for that myocardial ischemia, not only structural causes, that patient will come back to you complaining of angina. So you treat the stenosis, but maybe you didn't treat the patient. So this is why we are discussing here. So one thing is to treat the stenosis, but we have to treat the patient, as you point out. You have to treat the cardiovascular risk factors. You have to, you see, we are referring patients to PCI without being given the chance to medical therapy. So if we properly use this wonderful tool called PCI, maybe the outcomes will be better.
Yeah, and I think we have to keep in mind the slide that showed that basically the vast majority of patients that come to the cath lab do not take anti-anginal, and that is, I think it should be a lesson to all of us when we assess our patients and do an invasive procedure to think twice on what we're going to do. Now, there are a couple of questions on, say, the comparison between trimetazidine and ranolazine, and if you should use ranolazine after PCI. So if you want to get a start, then I will follow.
Okay, very quickly. Ranolazine came to Brazil in the last 2 years, and trimetazidine has been here for 20 years. So, of course, my experience with trimetazidine and ivabradine is much larger than with the ranolazine. Ranolazine has a couple of issues that you have to be aware of if you're considering to use. The safety profile is one thing. It may increase the QT interval, so be careful with that. It also drug-to-drug interactions. So many drugs do interact with the ranolazine. Many hypertensive drugs used for diabetes, for hypercholesterolemia. So you have to be very careful when considering ranolazine because of the safety profile. So in my experience, we have a very small experience with ranolazine. We use it as a last resource after trimetazidine, after ivabradine. And since the majority of the patients can do well on both drugs, ivabradine and trimetazidine, I must confess I have very few patients on ranolazine.
In our country, we have trimetazidine for many years, and we are using trimetazidine, and it works in patients who are complaining of angina despite receiving the beta blocker, CCB. And unfortunately, ranolazine will not be available, but it will be available maybe within 2 months. And we know the benefit of ranolazine according to Cariza's trials, which proved the benefit of ranolazine in relieving angina and improving the exercise duration, exercise performance. So it works well, ranolazine, in patients who have refractory angina, despite using all the available anti-angina medications.
Yes, we also have to remind our audience that there was a specific trial with ranolazine post-PCI. It was the River PCI that basically didn't show any benefit in reducing angina, in reducing events, with a trend with the problems on safety with ranolazine. So I think that the data we have on safety on with trimetazidine today should lead us to give a preferential use of trimetazidine. What we've learned in the past few years, because when ranolazine came on the market, there was a contraindication for use with trimetazidine, is that the two drugs are not mutually exclusive. So the two drugs can be used and together as good anti-anginals. I mean, in the past, we used to use nitrates and calcium channel blockers, and probably this is the future for those patients that have been treated with either drug and where there's a need of additional anti-anginal therapy. So I think that probably that is a good take from what we have, but in terms of safety, probably we have more data with trimetazidine, and for this reason, we should give a preference. Now, regarding a practical question to you both, is how do you follow patients after a PCI? Now, what is the practice in your countries? Because here, for example, after a PCI, we send it back to the GP and we see patients after 3 months if there are no other issues. So what is your practice?
Well, in Brazil, if I may start, in Brazil, Professor Rosano, we basically follow our patients on a clinical basis. So the procedure was okay, revascularization was deemed to be complete, and the patient is okay. We follow the patient on the clinical grounds only.
I think in our country the same. The intervention cardiologist is following the patient who was subjected to PCI, and clinical evaluation, proper treatment for hypertension, diabetes, dyslipidemia, LDL is well controlled, and as long as the patient is asymptomatic, so we are seeing the patient every maybe 3 months, except if he developed recent symptoms, angina, then we need to see the etiology and asking for investigations. But overall, patients are followed in the outpatient clinic after the PCI procedure.
And amongst the many questions that have come, then how do you individualize your therapy after a PCI? I mean, you make sure that you have, of course, all the preventative strategies, but then which preference do you give? Do you discharge patients with anti-anginals or not?
Well, first you have to assess, you have to be sure that the PCI was well indicated for a patient who was unresponsive to medical therapy before. And then if the cause of the symptoms were true fixed stenotic artery, the PCI should ideally have fixed this patient. But then you have to be sure that you did the right procedure for the right patient. And if that's true, you just ask your patient, how is the patient performing his or her daily life activities? Everything is normal, he can exercise, no symptoms. And then again, you have to assess this patient as a regular patient with chronic coronary syndrome. Is the patient, how is the quality of life? Is the patient feeling okay? He's being to play soccer. In Brazil, we say soccer with his or her grandchildren. So how the patient is feeling, and then of course you have to assess if there's need to a complementary anti-angina therapy. If the patient has underwent an incomplete revascularization, maybe there will be some degree of myocardial, residual myocardial ischemia, residual symptoms. You have to assess it individually.
So I think shared decision-making before PCI is very important, especially in patients who are not at high risk. Patients has no left main, for example, and just moderate ischemia, and he's doing well on anti-angina medications. So before sending the patients to PCI in chronic coronary syndromes, shared decision-making about the benefit and risk is very important, because some patients are still have angina in spite that they were not an ideal candidates for PCI based on, if we are applying now with the ischemia trial, I think we will intensify the medical treatment more to postpone unnecessary interventions.
Well, thank you both. We have so many more questions and too many to answer in the limited time that we've had for this webinar. I think it's been a great webinar. We have learned a lot on the pathophysiology, on how to monitor, on how to assess patients post-PCI, on the importance of medical therapy, not just after PCI, but even before, because we've learned that there are many, many patients who are receiving no medications at all. So I think that we have to keep all these informations at hand, and also all the notions that we got on the effect of trametaside and avapritinib in patients with refractory angina, with patients post-PCI, and especially the studies that were specifically dedicated in patients with angina after PCI are very relevant and show a clear role of these medications as a key medications for any patient that are with chronic coronary syndromes. So we will have many more occasions in the future to see both Professor Abdelhamid and Professor Godak in our future webinars. And I will suggest all of you to keep updated with the news on the Angina updates website, to follow all the new publications, to follow also all the practical clinical courses that will be uploaded in the months to come. So for now, good night to those of you who are in Asia. Good evening to those who are in the central part of Europe and Africa, and good rest of the day to all of you who are in a bit more on the west side, like Brazil. Thank you all. Bye.
Thank you very much, Professor Rizan. Thank you very much, Professor Godak. See you.
See you.